Welcome back. I should welcome myself back, but I met most of you last week, but there are some new faces. So just to introduce myself, my name is Jennifer Gerhardt. I'm the Vice President of all the community-based programs, including this program at High Point Treatment Center. Ariel Shapiro is the Program Director for Coordinated Care Network for High Point. So we have been participating in this training for the last month. I think before you guys there was a cohort of staff that started 2 weeks prior to you guys starting. And you guys are our second cohort of staff that are starting as care coordinators. So we're thrilled to kind of have this new initiative be kicking off, and as of, I think, Thursday late, we actually have the list of members that we have been sent to us from Mass Health. So we actually have people that you're going to be getting assigned to you as of Friday. So that's exciting. This is real now. It's not just in theory. We actually have real people that need help, so that you'll be getting very, very soon. So that's very exciting. I know you've digested a lot of information over the last few weeks, and let's see, it's Tuesday today. You have a few more days. You'll be getting, have you gotten your laptops? And so some people have, some people haven't, getting your laptops and your cell phones, and you'll be trained in the Care Navigator software this week as well, and that will be really what you're going to be using to entering all your information about your clients and tracking all the things that you need to be doing and your comprehensive assessment and your treatment plan and all your outreach and engagement attempts that you make with your clients, and everything else that you do is going to be inputted into Care Navigator. So that will be a work in progress. In your first 3 months, you'll be doing a lot of practice on Care Navigator, as well as while you're getting your cases, working with your supervisor on inputting all the things that you're doing with the people that are assigned to you. So I just kind of wanted to start with that introduction. What we're going to be doing for this morning and the rest of today is, one of the things that we wrote in our proposal was that we were going to be introducing you guys to what's called the SHARE approach. And what I just want to preface by saying the SHARE approach is a shared decision-making process where you or the professional works with the client, the consumer, on what their goals and objectives are going to be in a shared decision-making way. So it's exactly what it says. It's shared decision-making. You are not deciding for the client. The client's not necessarily deciding everything on their own. It's a shared approach where you're working together to come up with what the best decisions regarding their goals and objectives are going to be on their person-centered treatment plan and who they want involved in that. That being said, the SHARE approach is extremely technical. It is something that takes days and days and days of training to become certified in using SHARE. It's done with medical professionals, doctors, not just behavioral health and care coordinators, but lots of different professionals that are working with clients on shared decision-making issues. So Ariel and I are not certified in SHARE, so I want to make that clear. What our goal is to introduce you into some of the concepts of SHARE so that you can start to think about shared decision making when you're working with your clients, when you're doing the work with them and forming their treatment plan and goals. As I said, down the road we may decide that SHARE is something we all want to get certified in, and then there's also a train the trainers course that you have to take and all of that. So as I said, it's very, very involved. So this is really just the philosophy of SHARE, what some of the concepts of SHARE. This isn't something you have to memorize. It's a tool that you can use and a thought process that you can use in terms of working with your clients. So what we're going to be doing is going through some of the concepts, what it is, so you know what it is, how it came to be, what some of the research behind it is, and then looking at the kind of what does each acronym, SHARE, they each stand for something. So we will be going through what they stand for, and then kind of we're going to be looking at a comprehensive assessment. We have a mock comprehensive assessment that we've done that we are going to be giving you each table. So you actually have a whole filled out comprehensive assessment from soup to nuts as you know how long those are, that you can use as a guide just when you're doing your own comprehensive assessment. So it's a tool for your tool bag, but we're also going to be looking at that comprehensive assessment, if you were working with your client, how you would actually implement some of the concepts of SHARE in developing the person-centered treatment plan. So there's a lot of practice that's going to be going on, but it's all good. What I've heard from the first cohort is that the practicing is something that's helped them the most versus just hearing somebody speak and going through a PowerPoint and saying, okay, there you go, now go off and do it. It really, the actual practicing has really helped the first cohort. That's the feedback that we've gotten. So that's what we're going to be doing, a lot of practice and using some of the concepts of SHARE. So I'm just going to be doing a little introduction. I'm going to be pretty much reading off the slides about what is SHARE, okay? So what is the SHARE approach? The SHARE approach is a 5-step process for shared decision making that includes exploring and comparing the benefits, harms, and risks of each healthcare option through meaningful dialogue about what matters most to the patient. They use patient throughout this presentation, so we use enrollee, member, client. The way the contract is written, I think I mentioned this last week, we had to use the term assigned or engaged enrollee or enrollee. So if you hear us calling it enrollee, that means client, but they use patient for this. So the training goals is to better understand shared decision making and the evidence-based resources available to do it. So SHARE uses a lot of things that have been tested by research. That's what evidence-based means. And to better understand what it takes to implement shared decision making in practice. So SHARE consists of 4 modules, including the introduction that we're doing now. Module 1 is shared decision making. Module 2 is actually the resources that they researched that were helpful. They call them AHRQ PCOR resources. Module 3 is communication, and Module 4 is putting shared decision making into practice. The SHARE approach has a participant guide that goes along with it, with 3 slides per page. I don't know, we're not handing out the guide, so just FYI on that. So now let's get started. So that's just a brief introduction to SHARE. Ariel's going to kind of get up and go through Module 1.
So, Module 1, we're going to be breaking down the shared decision making and the SHARE approach. So the purpose of this module is to present information about the 5-step SHARE approach of shared decision making and how to implement it. The learning objectives, at the end of the slides, you should be able to define shared decision making, list critical elements required in effective decision making, explain key steps to conduct shared decision making. So breaking down the what, why, and when of shared decision making. So what is shared decision making? It occurs when a healthcare provider and a patient work together to make healthcare decisions that is best for the patient. The optimal decision takes into account evidence-based information about available options, the provider's knowledge and experience, and the enrollee's values and preferences. So the SHARE approach, like Jen had mentioned in the introduction, it's a 5-step approach for shared decision making that includes exploring and comparing the benefits, the harms, and the risks of each healthcare option through meaningful dialogue about what matters most to the enrollee. So breaking down the 5 steps, so the S of SHARE, step 1, so seek your patient's participation. Step 2, help your patient explore and compare treatment options. Step 3, assess your patient's values and preferences. Step 4, reach a decision with your patient. And step 5, evaluate your patient's decision. Later on in the day, we'll be breaking down the steps and you guys will be able to practice going along with them. So within the 5 steps, there are 9 essential elements that in 2006, 2 researchers were able to identify and break down what the 9 elements of shared decision making are. Based on the findings of their review, they described the 9 elements. They described that they should be part of any shared decision making that is done with an enrollee. So breaking down what the 9 elements are, define and explain the problem, present options, discuss benefits, risks, and costs, clarify patient's values and preferences, discuss the patient's ability, self-efficacy, discuss doctor knowledge and recommendations, check and clarify the patient's understanding, make or defer a decision, and arrange for a follow-up on the decision.
You can see they use doctor, so this is very medical. Like I said, this is meant for all healthcare, including doctors.
So the benefits of shared decision making, there are quite a few that they were able to identify that the enrollee would benefit from. So first off, it would improve the enrollee's experience of care because they get to have a say in what their treatment looks like. Improving the enrollee's adherence to treatment recommendations. There's also emerging evidence that it can improve health outcomes. Since they are part of it, they will be more apt to actually following through with it and getting the treatment that they need. So when should you engage an enrollee in a shared decision-making process? So it begins when your enrollee has a health problem that needs a treatment decision. Remember, not every patient encounter requires shared decision-making. Some patients may not want to or may not be ready to participate. The enrollee choosing not to participate in the decision-making process is still a decision on their end. So what studies are showing about shared decision-making? They suggest that many healthcare professionals believe patients are not interested in participating in their healthcare decision-making. However, evidence suggests that most patients want more information than they are routinely given by their provider. And many would like to be involved in making their own healthcare decisions. And with the wanting more information, I want to add, they want more information that they can understand. We'll touch upon that more on the 3rd module of communication as well. So looking at the who and the how of shared decision making. So who's involved and how do we do it? So in a clinical setting, the entire behavioral health and medical team should be familiar and involved with shared decision making. This is not a universal tool that's always used all around, so we'll be trying to help other providers as well learn and understand the benefits of it when we are working with them on coordinating care for our enrollees. Family members are also an important part of the team, or caregivers. They have a high influence on decisions that are being made by the enrollee, so they can lend support in clarifying values or preferences to the behavioral health or medical providers, and they can be a legal proxy for children, elderly, or seriously ill patients as well. There are other medical team members that could be part of the team, not just the PCP. That could be medical treatment specialists that need to weigh in on decisions before they are made. So this is where it's really important to make sure we are getting releases for all of the medical providers that could be involved or that are involved with an enrollee, so that we are getting all of the input before guiding them into what would be best for their outcomes. So assessing your patient's values and preferences, here are some tips on how to do that. So encourage the enrollee to talk about what is important to them regarding their options. Use open-ended questions and avoid questions with yes or no answers. Listen actively to the enrollee. Show empathy and interest in the effect that a problem is having on your patient's life. Acknowledge the values and preferences that matter to the enrollee. Come to an agreement with what the enrollee prefers and what they find important in their treatment. So this conversation starter box, it'll be helpful when we do our activities this afternoon. But some things to ask when you are trying to assess their values and preferences, they're all open-ended. So think about the way you would word it to feel comfortable in the situation. But they say an example they give is when you think about the possible risk, what matters most to you? As you think about your options, what are important to you? Which of the options fit best with the treatment goals that we have discussed? Is there anything that may get in the way of doing this? So assessing preferences matters, especially when the patients defer decisions to the clinician. I think we talked about this last week, where the patient says, well, you're the professional, I'll just let you choose what would be best. So this is encouraging them and empowering them to be able to make their own decision when it comes to their treatment. So finding out what matters to the patient greatly impacts achieving satisfactory health outcomes and patient satisfaction. So reaching a decision with your patient, this slide kind of breaks down some of the questions to help your patient finalize what the decision is that they're going to be making. So asking them some questions like, it's fine to take more time to think about the treatment choices. Would you like some more time, or are you ready to decide? What additional questions do you have for me to help you make your decision? So now that we had a chance to discuss your treatment options, do you have a preference for which treatment you would prefer? Which treatment do you think is right for you right now at this moment in time? So this is helping them narrow it down. Evaluating your patient's decision. So once a decision has been made, it's important to follow up with the enrollee on how they are doing. Evaluate their decision. So for patients facing more life-threatening conditions, some of the decisions will be irreversible. This is more for the medically complex enrollees that we may encounter. So this is where you want to be careful with what the follow-up looks like and make sure that they are making the decision that's best for them. Decisions related to more management of chronic diseases, it should be revisited periodically. So it's not just like, oh, okay, we made this decision, you can do it now, you're on your own. Make sure you're following up with them. Their decision might change from now and then. So having conversation with them about why their decision is changing or why it's staying the same if you think something's not working for what they have decided on. So being open and having a discussion, helping them understand pros and cons of the decisions that they're making. Some tips around evaluating your enrollee's decisions. So make plans to review the decisions in the future. Decisions may be reviewed and changed if they are not working well. So kind of like with the care team meetings, plan ahead for the future for when you're going to revisit this with them. Let them try it out for a few weeks or a few months, whatever is most appropriate, and then pick a time and day that you're going to say, okay, we're going to look back at this, see if any progress has been made, see if anything needs to change, and so forth. Monitor the extent to which the treatment decision is implemented. Help with managing barriers to implement a decision. Provide access to self-management support programs or other resources. Reconsider other options if the preferred options are not working. So you want to let your patient know that you will continue to evaluate the decision that was made throughout their course of treatment with us. Keep the communication avenues open. You can say something like this: so let's plan on reviewing this decision at our next appointment. If you don't feel things are improving, please schedule a follow-up visit so we can plan a different approach. Most likely we will be the ones planning these follow-up visits with them. This is example is more of like a clinic-based setting, but since we are community-based, we'll be the ones reaching out to them to set up their follow-ups. So for Module 1, you have to keep in mind that shared decision-making is a two-way street. It occurs when a healthcare provider and an enrollee work together to make healthcare decisions that are best for the enrollee. The optimal decision takes into account evidence-based information about available options, your knowledge and your experience, and the enrollee's values and preferences. Again, the SHARE approach is a 5-step process for decision making that includes exploring and comparing the benefits, the harms, and the risks of each healthcare option through meaningful dialogue about what matters most to the enrollee. They are the leader of their care team. It's something to keep in mind if you keep thinking of it that way. We are the coordinator, so we're getting everyone together, but the enrollee is the one who ultimately makes the decisions of how they want their treatment to look, what's going to work best for them, and if they will be able to reach their goals that we're helping them do, helping them create. Next slide. Use conversation starters. They help to engage the enrollee as you present each, as you go through the 5 steps of the SHARE module. Most of this will be done in conversation with your enrollee. It's not like you're breaking down and letting them know, like, hey, we're going to do a step 1 of this module that I learned about. It all comes in conversation that kind of flows naturally, but you're having it as a guide in your head so that you keep it structured as you're working through the treatment with the enrollee. This is a nice visual of the breakdown of the steps of shared decision making. So if you look, it starts with step 1 over here. So seeking their participation, communicating that a choice exists, and invite the enrollee to be involved in the decisions. Step 2, help the enrollee explore and compare treatment options, discuss the benefits and the harms of each option that's available to them. Step 3, assess the enrollee's values and preferences. Take into account what matters most to the enrollee. Step 4, reaching a decision with the enrollee. So decide together on the best option and arrange for a follow-up appointment. Step 5, evaluate your enrollee's decision. So plan to revisit the decision and monitor its implementation. And then goes into citations of all the research that was done that breaks down how these 5 steps and the 9 elements are beneficial in the work that we're going to be doing with the enrollees. So next we're going to look into Module 2 with Jen. That is the P-Core. I forget the
Very dry.
Yes, it's a little dry. But she does a great job of explaining
Yeah, right.
it.
Okay. So while Ariel's pulling that up,
So how often do you guys think about when you go to your doctor and say they recommend that you say you smoke or you need to lose weight, or they'll say, here's what you need to do, and that's kind of it. We talked a lot about motivational interview, not a lot, but we touched on motivational interviewing last week, and I know you're going to be getting some training in MI and trauma-informed care. I think either tomorrow, I think it might be tomorrow. But when you think about your own situations, when doctors, they have you go do blood work, then you get something in the mail and it says decrease your cholesterol, or you need to, it'll give, recommendations, or sometimes your doctor gives you, this is what you need to do. How often does your doctor or your PCP really involve you in, what are you ready to do about this? Where are you at? Do you understand the risks of your deciding to continue to smoke? Or do you understand the risks of not changing your eating habits regarding your diabetes or your issues that you're facing regarding your heart? What are you ready to do? Where are you at? What do you want to do? You don't get that very often, at least I know. I don't for my PCP. You know, you certainly get checking on everything and telling you what you need to do, but how often do you feel like they're involving you in terms of where you're at with making a decision about what you want to do about an issue that you're struggling with, or a recommendation that they might have regarding your health or your behavioral health? So that's really kind of what you want to do. If somebody says, I'm not smoking, I'm not stopping smoking, that's how I cope with my stress. I'm going to gain weight if I stop smoking. I'm not going to. Then what you might want to do is engage them in, what are you ready to do? Are you ready to learn about educationally what your options are to maybe smoke less? Or, you know, so that's kind of, you know, a first step might be even education regarding, you know, what stage of change that they're at. So I think that when you're doing shared decision making, you kind of have to remember that your patients can't jump to, if their lifestyle is such that they're so used to doing something and they see it as a coping mechanism or something that would be very difficult for them to stop doing. You need to take baby steps, and education is a first step in terms of what they're willing to do. So again, kind of going, I know that we as our professionals want to have these great treatment plans. I think I talked about this last week. You know, oh, we're going to, you know, help, they're going to get a nutritionist, and they're going to see them, and they're going to change what they're eating, and they're going to go on walks every day, and they're going to, and you know, we can't have these elaborate goals all the time depending on who our member is if they're not ready to do those things. So that's where the shared decision making also comes into play, that you're really helping, what are you ready to do? And what, you know, what do you think you can do? And what do you want to do? So I'm just reinforcing that, and to think about your own kind of issues, because we all have lifestyle things that we need to change, or we all have our doctor's recommendations, and sometimes they are just telling us what we need to do, and we just go, okay, and then we don't do it. Or because it wasn't really something that we were ever really, we didn't break it down into steps, you know, nobody ever helped us break it down into steps. So that's really what you're going to be doing with this, using this philosophy, if you will. Any questions? Okay. So module 2 is really using the patient-centered outcomes research, and that's what that stands for. PCOR is patient-centered outcomes research in shared decision making. So what is PCOR? It's also known as comparative effectiveness research. And what is patient-centered outcomes research? It assesses preventive, diagnostic, therapeutic, palliative, or health delivery system interventions. It compares the benefits and harms of the interventions. It aims to find out how well interventions work in everyday practice settings, not just in clinical trial settings. And it focuses on the outcomes that matter most to people. Patient-centered outcomes, outcomes that patients notice and care about when they make their healthcare decisions. And remembering that each patient is different, and what matters to one may not matter to another. So they give an example. High blood pressure and high serum cholesterol levels may not cause alarm or lifestyle change for some patients, even though you might think, oh my God, how can that not? I know I actually do still have a client that she has lupus and she has blood clots and she's had all these health issues, and she's at a place where she's like, I am not gonna get this experimental surgery. I don't want this. I know that's a risk to me. She recently had a seizure. She's in the hospital now. And she's not at this place where she wants to go through all this experimental kind of stuff that needs to happen for her that the doctors are recommending. So, you know, that's a difficult place to be as her therapist, regarding respecting her decision and knowing that her decisions may cause her to get sicker. So that's not, and again, that goes into the risks and seeking supervision on decisions, you know, that they're not willing to say, I'm not willing to go through this sort of procedure. That might actually help them get better, but they're so tired of dealing with so many procedures and so many, and it's maybe not gonna extend their life that much more. So, you know, there are certain people that feel that way, and again, assessing their preferences and what the risks and, you know, their value system is regarding some of those things. Good shared decision making means talking with your patients about what is important to them. So outcomes that matter to patients or enrollees may include the quality of life, and that's what I was just kind of talking about, mobility, ability to carry out certain tasks, ability to focus, ability to return to work, side effects or risks of treatment, symptoms such as pain and nausea that the treatment might occur, or if you don't get the treatment might occur, and survival. And consider that outcomes might be different for each patient. The primary aim of PCOR is to help inform patients, healthcare providers, and others as they make healthcare decisions regarding how. In a clinical setting, use PCOR as your base in shared decision making. So help your patients compare and weigh options, learn what's important to them, and engage in two-way communication. So as you can see, these concepts are all kind of, they keep kind of saying the same thing in a little bit of different ways. Evidence-based information about treatment options can help your patients be active participants in the shared decision-making process. PCOR is tools, not rules, so there's no real rules to it. It's informative, it's not meant to dictate healthcare decisions, and it allows you to help your patients come to a decision that works for their lives. What PCOR does not do, PCOR does not tell health providers how to practice medicine. It provides guidance by itself and is informative. It is not to replace clinical judgments tailored to each individual client or patient. And it is not to replace clinical practice guidelines or provide clinical recommendations. Sharing decision aids with patients improves patient care and outcomes. And there's a growing body of literature that shows providing patients with decision aids regarding their health treatment or screening decisions can have positive results. Sharing decision aids with patients improves patient care and outcomes. So sharing decision aids with patients improves patients' knowledge regarding their options. So again, providing information, providing knowledge, it really gives them the knowledge that they need to say, okay, I have all this education and knowledge about my condition or and the risks and all of this, and I have my options of what I can do, and now here's what I'm deciding. It reduces their decisional conflict. It increases patients' active role in decision making. It improves accurate risk perceptions of possible benefits and harms among patients. It increases the likelihood that patients' choices are more consistent with their informed values. And it enhances communication between patients and their clinicians. So the key takeaways with this module is that the primary goal of PCOR is to help inform patients or enrollees, healthcare providers, and others as they make their healthcare decisions. And AHRQ's Effective Healthcare Program offers a variety of evidence-based PCOR resources for health providers and patients to support shared decision-making. And you can access and order all this material online. And here's the citations. Any questions really about, not necessarily each module, but just about the whole process of what we're talking about regarding engaging your enrollees in shared decision making? Yes.
I have a question. So I understand, like, to help the enrollee make a choice on the best treatment, speaking to the healthcare provider, you would get the information, but would you do any more other research, like online or anything, to basically explain the situation to the enrollee? Or would you just receive the information through the healthcare provider?
I didn't quite hear everything you said, sorry.
When you're helping your enrollee make a decision.
Yes.
For their whatever procedure or illness, do you just receive the research through their healthcare provider?
So, yeah, I mean, I would want to have a discussion with their healthcare provider, especially if it's a medical, obviously if it's a medical issue, which is why we involve the PCP or his or her designee as part of the care team. But you can always research, educationally.
Okay.
You can research things online all the time. I mean, I strongly suggest helping your client research and learn as much about their risks and benefits of certain treatments, or what options they have, or what the risks are of doing nothing, what the risks are with that. And again, some people might not be as alarmed for whatever reason, and it might be a cultural issue, it might just be they've been involved in health issues their whole life and they're tired and don't want to make any changes at this point, and they've looked at the risks of that and they're willing to accept whatever the risks are. So you can't force a decision on your client or your enrollee, but most people want to get better, so think about the majority, not the minority. Most people want to feel better. Most people are in treatment because they want to feel better. And if you ask them, what do you want to change most in your life, they'll generally say something like, I just want to feel better. I want my life to get better. I want to stop having to go into the hospital, or I want to, just again, feel better about my health and my wellness and my social situation, and I don't want to be as lonely, and I want to be healthier. And that's what you're going to get from the majority of your members or your enrollees or your clients. So just, think, when I bring up the exception, I bring up the exception to make a point, I think, is what I'm saying. So most people are going to want to take baby steps toward treatment of what's going to make them feel better with whatever the issue is. So just keep that in mind as well. But also keep in mind the baby steps and where they're at, what they're willing to do. I think I had a client who, I know I bring this up a lot, but he had a huge amount of health conditions, and he was able to get clean and sober for a huge amount of time, and he had to have a liver transplant because of his alcoholism, and he made it through that, and still his PCP and his other specialists were telling him to stop smoking, and he was able to, I think, I'm still seeing him, he was cut down to 6, I think he's now doing 6 cigarettes a week. Wow. But it took him years to get to this point, and knows he has to, because everybody tells him you can't smoke, and he's still weaning down and has tried things like all the alternatives, and he hasn't done Chantix yet, and I think he's going to be doing that, or at least he says he wants to do that. But I've just an example of something that takes years, which is where a doctor is telling him you can't at all anymore, because of everything else he's been through and whatnot. So, and his immune system and just everything. So again, just to bring up an example to make a point. Any other questions? Yes.
I don't know if you probably asked this before, you probably asked it, but is there a common age that we're going to
It's hard to hear from back there, so can you talk?
No, I'm saying, is there a common age, most common age that we're going to be working with, range, between, I know it's 18 and above, right? But is there a common number that we're going to be dealing with, population that we're going to be dealing with? Okay,
No.
That's one. And then 2, for the elderly, is there a different approach to them? Because you said something about surgery, and that person didn't want to do it. I know most common elderly do not want to do, when it comes to surgery or any kind of medication they don't want to deal with. Is there a different approach for us to work with them?
Is there a different approach to work with older?
Any kind of research in regards to that?
So, sorry. So there isn't necessarily a different approach, but I think you need to assess where they're at cognitively.
Right.
How are they making their decisions? Are they able to make rational decisions? Do they have a proxy? All those things that can happen when you get older. I have another client that I'm working with that I think I brought this one up. She lives alone in her house, and she, has so many medical issues. She's not good at cooking or making her own meals. She isn't good at, cleaning and doing she's just has trouble getting around. She doesn't even go outside. She refuses to look at alternative living situations right now. She's cognitively pretty intact, though. But if she wasn't, that might be something that I would really need to pull in some of her support system and or doctors or whatever. But right now the doctors aren't even, they're telling her she shouldn't live on her own, but they're not saying it's life-threatening, right? But she refuses. And she also has social phobia, so she doesn't like being around people anyway and around crowds. But her cognitive skills are intact. So that just plays a huge part in terms of what they're capable and how they're making their decisions. And sometimes people can be influenced too, the older they are, by their family supports, other people that you want to pull in, and not just the professional saying, and again, it's really hard to get into this whole prescribing. Like when I'm with her, I want to say, like, you really can't be living on your own. You know that, right? And
So
these are all the risks. And she, I know I can't really take that approach with her because it's not gonna do anything.
Is she
So-
not able to get someone to live in with her?
Hmm?
Is she not eligible for resources that could provide someone to live in with her, like a live-in home health aide or something?
Yeah, she's
Or she just
eligible
shut
for
down
some
to-
of that, but she doesn't. She's
She
not
doesn't
gonna
want
move.
none of it.
No, she won't even go look at a place, more or less. And her life isn't she's not like in this life-threatening situation. She does enough for herself in the small little house that she lives in, but, and she has enough resources, like if her power goes out, her cousin or whatever comes and gets her and brings her to her house or things like that. So, I don't worry about her necessarily all of a sudden waking up and, unless she had a heart attack or something like that. But
So if they refuse services altogether, where do we go from there?
say that again?
If they refuse services from us, right?
Yes.
Say we're having a meeting and then they decide they don't wanna work with us, where do we
Right.
go from there?
So, and again, it's looking at all the options and weighing the risks and benefits and things like that. As I said, I'm bringing up some exceptions to what you normally would see, What you're normally gonna see is you're not gonna have somebody necessarily with social phobia that wants to maybe be around, because that's another issue with her. She doesn't care if she's alone, like, for the whole day. And just would almost rather, than go to the senior center or go play bingo. And she tried, I think I prescribed that for her, and she was, laughing about when she went, saying how ridiculous it was, and she, like, I did it for you, and, and I don't want her to do it for me, you know what I mean? So, again, it's hard to not get into that prescribing when you know that you think something's good for that person that they're not willing to really engage in at that time. So, but as I said, and I again bring up the exceptions sometimes to make a point, in that most people are gonna wanna take those baby steps to get to where they wanna feel better. Any other, before we go on to the communication, any other thoughts? And again, you're gonna have a wide range of ages and issues and whatnot, so you're not all gonna have like homebound, social phobia, people that don't wanna go out of their house, so, with tons of medical issues, so, but you might. Okay.
Alrighty, so in Module 3, we're going to be looking at the communication with our enrollees. It looks at a variety of communication. In the full length of the module, it was a lot around medical health communication and health numbers, things that we're not necessarily going to be going over with our clients in the role that we are playing with all of their services. so it has been condensed. But basically the purpose that we're going to be going through is to describe the role of clear health communication plays in shared decision-making process. Using effective communication will help you gain trust and build rapport with your enrollees during the decision-making process. So health literacy, they've done research to find out that more than 1/3 of adults in the U.S. are impacted by limited understanding of what health literacy is. Even people that are considered good readers have trouble navigating the healthcare system when they are sick, scared, or in pain. I want to note that even when they're not scared, sick, or in pain, it is confusing. I don't know if you guys have read even the letters that you get from Mass Health. If you've had clients before, just reading through them and you're like, wait, I have to read this again.
And by the way, I want to say something about that. I saw the letter, actually, I don't think I brought it, unfortunately. A letter did go out. We got this list of members that you guys are going to be getting assigned, and every single person that we got on our list got a letter from Mass Health saying, you're going to get a call from Coordinated Care Network, a care coordinator from us, and that's going to help you with navigating and getting resources that you need for your health conditions. And it was a good letter. It was good they sent it, but it's a letter that easily somebody could kind of say, what is this, and put it aside and not really read it or understand. What's a care coordinator anyway? Oh, this is just promotional, blah, blah, blah. So but that did come to our attention yesterday. So when you're making contact with them, you may want to say, I know you recently got a letter from Mass Health about this benefit, which is, again, free, something that can be really helpful to you, whatnot.
Yes. And also, like with all Mass Health letters that do go out, they're in unmarked envelopes, so a lot of time people do think that they are just junk mail. So don't be surprised if they don't know what you're talking about. So when you are talking with the enrollees about the healthcare system, make sure to use universal precautions like speaking slowly, avoid using any jargon, check in with them to make sure they are understanding what you're communicating, and offer easy to understand decision aids if you have those available. So the teach back technique. This is when enrollees are using their own words to explain what they need to know about their health or what to do to get better. It helps you make sure that you are conveying the information to them in a way that they can understand, and it can happen really fast. It just takes as little as 1 to 2 minutes. You just have to prompt it to make sure that they are able to say back what you said to them. So what to say when you are using the teach back technique during shared decision making. So explain things clearly in plain language and avoid any medical jargon or vague terms. In our role there are a lot of acronyms, and we just get used to it and we assume everyone knows what the acronyms are. So that is just taking a step and being mindful of breaking down everything and explaining to them what they mean. Make sure your enrollee knows your goal to check how well you explain the health information and you're not trying to test their knowledge. So before you go into explaining, just say, I always start it with, stop me if you have any questions. Most of the time people, if they don't understand, they won't stop you because they don't want to look like they don't know what you're talking about. So explaining to them, at the end of what you're saying, you're just going to ask them for how they took it or what they understood from what you said. Is just a nice way to kind of segue into making sure that they're understanding the information that you are conveying. So it only takes a few minutes to implement. You can try it when you are explaining concepts that you'll be talking to them about more frequently, such as the treatment options, any clinical trial participations, the risks and benefits of what you're going to be working with them on, and their adherence to the treatment plan that we are creating with them. So some takeaways from the communication piece. Offer your enrollees appropriate decision aids when applying shared decision making with them. For example, use decision aids that are culturally sensitive, easy to read, and in multiple formats, such as print, video, and audio for enrollees that might have communication challenges. There are a few pages of citations because it took a lot of research to go into finding out what would work best for the population we are serving, in order to make sure that they are having their say in treatment and that they are understanding what is going on with their treatment. A big thing with the shared decision-making approach is having patient say in it. So if they are not really understanding what's being told to them, they might not understand why we are guiding them towards an appropriate decision for their treatment, and that's where you might get some pushback. So just make sure everyone's understanding what's being said. And then same for languages. If there are any disabilities like a hearing loss, languages, low cognition, anything like that, just be aware of it, and that's where collaborating with other medical providers on the team can help you gain the understanding of how we need to communicate to each individual enrollee. Any questions? Okay. Great.
All right, so this is putting it into practice, and as I said at the beginning, we did a comprehensive assessment, an example of one that you're going to be going through and creating a person-centered treatment plan using the steps of shared decision-making, or attempting to use the steps of shared decision-making. Remember, this is a tool. It's not something that you're mandated to do, and again, we're talking about how it can be helpful. So putting shared decision-making into practice. So the purpose is to introduce key activities and strategies to consider as part of incorporating shared decision-making into practice at your organization, including obtaining leadership support. So again, this was written in our RFR as a tool that we were going to give you guys, so it is supported from your organization, just FYI. You're going to conduct ongoing evaluation, so an informal evaluation to a formal evaluation, gather feedback on what works and what needs improvement, share success stories, meetings, emails, newsletters. So, you know, this is how they've kind of gotten some feedback about shared decision making and success stories and using it. Key takeaways is implementation of shared decision making involves a number of activities. Start by developing an implementation plan. What does what, when, and how. Choose an approach that works for you in your setting. Start small and then scale as you get experience. Evaluate your efforts and share feedback with the entire team. So when you're doing staff meetings, you're going to find that you're going to do staff meetings, case presentations at your organization regarding your caseload. In supervision, you're going to be discussing, you know, kind of how did you come to your treatment goals? How did the client participate in those goals? Things of that nature. You might present a case and say, here's some of the things that I did that were really helpful in coming to helping the client and I decide on what they were going to be working on together, and here's how we assessed whether it was working or not working or whether or not it was going to change. And again, the citations. So that's really kind of more an evaluation of and or an ongoing process of sharing how using some of these tools and techniques has helped you and or your team and or you with your caseload. And again, we're gonna be practicing, and you're gonna, I mean, again, this is something you learn as you move forward. So this is not something that you have to be experts at. This is just a tool that you can use in helping engage your client and help them participate. Because what the research has shown is if they agree on their goals and they're actively participating and forming them, they're much more likely to follow through than if they're told what they need to do. And, you know, obviously that's pretty straightforward. And again, I always think about my own self. If I'm just told what I need to do, I might not necessarily do it versus my coming up with the steps that I need to do to achieve something that I want. And it also has to be a goal and an achievement that the client wants. If you're just telling somebody, again, that they need to exercise more, or you know, they need to eat differently, or they need to get out and be with people more, and they don't want to do that, they're not focused on that right now, you're just telling them what you think they need to do, and they're not going to do it or take the necessary steps. You know, they might want to eat differently, but they're not willing to give up fast food right now. So you need to know that, like in terms of what they're willing to do. So again, you know, the shared decision making. What do you think we can do? What do you think you can do? What do you want to do? So, yeah. Do you have a question? Mm-hmm. Okay. Okay. Any questions before we move on?
We need Jessica to go.
I think what we need to do is introduce them to the comprehensive assessment, because we don't have copies yet. So you want to do that? Do you have it on the screen, please?
The summary?
Yep.
Okay.
So you can get up.
Yep. Alright, so we are going to be putting into practice what we just did from the share approach. Each table will be getting copies of the comprehensive assessment so that you can have it to review, but we also created a summary of the client that you'll be working with. The comprehensive assessment has been filled out for you so you can see the information and you'll be coming up with your table, a treatment plan for the enrollee based on the information that you have in the assessment.
And when you're working with it, with your table, just be sure that you're talking about questions that you would ask the client, like how are you engaging them in the discussion of what their long-term goals, short-term goals, and then the steps, the tasks. If you remember the person-centered treatment plan, how would you be engaging? Don't just come up with what they are. How would you be talking about with the client about helping them participate in creation of the plan? Does that make sense?
Alrighty, so I'll read the summary of Loretta, who you will be working with your tables. So Loretta is a 33-year-old African-American female who lives in Brockton, Massachusetts. She currently lives in an apartment with her boyfriend of 8 years. He's verbally abusive and threatens to leave her and cut her off financially. She reports that he calls her derogatory names and puts her down daily. Her sister lives 2 streets away and she gets to spend time with her when her boyfriend permits. Loretta calls her mom on a frequent basis and enjoys talking to her. Loretta used to work at Dunkin' Donuts down the street, but was let go from her position when she was caught using heroin while taking the trash out during her shift. She reports that she only uses when she needs to let go from the stress of everyday life. She is fully in control on her heroin use and gets it from a good source that she trusts. She was referred to the BHCP services by her ACO for an increase in detox days over the last year. She was admitted 3 times over the last 12 months, most recently being in May of 2018. In March 2018, she was diagnosed with diabetes and is learning how to live with that disease. She is not open to changing her diet since she believes that she makes healthy choices with the options that she has. She is able to identify that she does want to get more physical activity. There is a park near her house that she used to go to, but does not have the motivation anymore. Loretta finds herself sleeping more and more throughout the day with less motivation to get up and do anything. There are no concerns with Loretta's mobility or communication. She is able to complete activities of daily living independently when she is motivated to complete them. She is referred to the BHCP with a mental health, substance use disorder, and medical diagnosis. So you're going to work with your tables to take the information from the comprehensive assessment and put it into the treatment plan. Think of the shared components while you are creating your plan.
We're gonna push you to make some.
So we have a summary of Loretta up on the projector for you to refer to as you're going through the assessments. I'll pass them out. There'll be 2 assessments for each table, so you guys can look on and share as you go through each section and find out more detail about Loretta. And then after that, I'll let you know. I'll put up on the screen the guide for the person-centered treatment plan, so you kind of have some structure to follow while you're going through it. And keep in mind what Jen had mentioned when we were doing the training on it, that it is flipped on the person-centered treatment plan. You'll see that it has the short-term goal first, then the long-term goal, but when you're working with a client, it's easier to think of the long-term goal and then break down the short-term goals and the tasks and so forth. I'll remind you again when we get to that part, but just so you know while you're thinking and taking down notes while you're going through the comprehensive assessment.
And have either all of you can write down your notes or take a note taker, because we're going to be asking you to come up and present what your plan is at the end that you come up with for Loretta.
Yeah, we got the.
So we are back now, and you guys were given the task to work on the person-centered treatment plan for Loretta using the concepts of shared decision-making while you were in the process of going through the comprehensive assessment, coming up with the long-term, short-term goals, tasks, and barriers. And so we are going to go by table and have you guys come up and present what you what you came up with for the person-centered treatment plan, but also any shared decision-making things that you discussed and any challenges or that you faced while you were doing the exercise or things that were helpful while you were doing the exercise. So I'm going to start Lee.
All right, I'll try to speak. All right, so we came up with 2 long-term goals. The first long-term goal was for Loretta to kind of follow her doctor's recommendations regarding diabetes and general health in the, in the hopes of kind of improving her general health. So under that we had short-term goal, which one she had identified as increasing her physical activity. And we broke it down, we had a long-term goal, a short-term goal, and then tasks under the short-term goal. So tasks that towards increasing her physical activity would be to call her sister to set a day to walk. She could also maybe walk once a week for 20 minutes. We also talked about her talking with her psychiatrist or therapist regarding a medication evaluation because she had identified decreased energy and increased sleep as a barrier. So we'd be kind of looking at the antidepressant that she's on. And also kind of giving her information about how increasing her physical activity will also boost her mood, but then the medication evaluation might kind of give her a little bit of a boost. Also, another short-term goal is improving her nutritional status. And the tasks under that, we talked about helping her go to DTA to apply for SNAP benefits, providing information on food pantries, and maybe asking her doctor for like healthy meal options and making sure she's educated on what to choose, what not to choose in terms of managing her diabetes. we talked about barriers to these goals as in terms of managing her health. The barriers were the poor nutrition, the decreased energy, the substance abuse, and really the relationship with her boyfriend and the domestic violence is a big barrier. But from reading the assessment, that didn't sound like something that she was really wanting to address at this point. We talked about her other long-term goal would be to obtain employment. And the short-term goal under that would really be addressing her sobriety. So, because she really can't obtain employment unless she's sober. So tasks for addressing sobriety would be to continue NA attendance, identify a sponsor, continue on the methadone program, maybe work with Loretta on identifying stressors and triggers to substance abuse, make a pros cons list of using. It looks like she had identified one of the triggers as the relationship with her boyfriend, so that may be a time to just like educate her around what kind of makes a violent relationship, and educate her around support so she knows she has those supports if she wants to use them. Under unemployment also we put short-term attending a work program, which would be tricky since the boyfriend doesn't really allow her out. But under a task, put maybe, going to DTA to apply for a work program and interim benefits, which actually now that I'm thinking about it, the boyfriend may see that as a benefit. So, and if he is very controlling, he may let her go apply for that, which would, benefit her ultimately. And again, for barriers to obtaining employment is the substance abuse, the domestic violence, her energy level. But we would, be giving her resources around the domestic violence, and even if there's things that she hasn't identified as goals, we can, start a conversation with her about it and give her resources, specifically on the domestic violence.
I really like how you broke it down into really measurable steps and manageable steps, and identified, that you might not be ready in certain areas, but that you would start a discussion and see where that ended up. So that was really good.
Hi, so we pretty much did the same thing as the first team. We came up with, first is a safety plan for the young lady, which would be, we talked to her mom and her sister, which lives in the neighborhood, and then also look to the police station for a safety plan, look for local shelters for DV, put on her safety plan. We also came up with long-term and short-term goals and barriers. So for the long-term, we came up with, reach out to her doctors, her PC, come up with a treatment plan, employment, and what else? Long-term.
The diabetes and nutrition.
Yep.
So we set her up with the DTA for food stamps to make sure she has food stamps, and show her what the food pantries are, and PNA service to make sure for her diabetes. And then for job, we also made sure to see if she wanted mass rehab, and then she has a psychiatrist, so just maintaining and following through. And
then we have short term. For the short term, we're gonna look for some physical activities. What is that one? Is that, yeah.
can't read your handwriting.
I can't read the handwriting.
I'll write his handwriting. But basically, we have to sit with the mass health. We broke it down to all
Yeah,
the
mass
things.
health, mass rehab.
Yeah.
Seeking, what is that, halfway house, sober house?
So we're also halfway
Yep.
house it for part of our safety plan.
Exactly.
Apparently, we're just all
Yep. All right, so,
Yeah.
which one is that one? What else? We're gonna look for nutrition for short term, it's a DTA SNAP, SSDI, hopefully doing an evaluation to see if she could get other services. We also talk about food pantry as well. What else?
We
covered all of our
The short
goals, yeah. Covered all our goals. Our goals were safety plan and her, job.
Yep.
And to help maintain for her to be able to, once she got a job and was able to, have a safety plan to get out of the house with her abusive boyfriend, then she could work on her long-term goals of nutrition and staying sober.
And some of the barriers are the boyfriend as well, the DV that she has, the substance abuse. What else? As far as the barriers. Depression. For her goals, one and her strength as well was one of the things you did say, she likes to cook and bake, so we could look for some things in the community, which we call culinary arts, to kind of get her going, to keep her informed. She has a park around the way, which also is another strength and goals, get her involved in activities. She was working, so kind of looking for, I guess, long-term as well, down the line, look for employment, get some kind of educational services, which kind of help with that, to keep her balanced.
So with the first two tables, how did the process feel? Did it feel, after you went through the comprehensive assessment, did it feel daunting? Did it feel like if you started with the long-term and then broke it down, that was more manageable? I'm just wondering how the process felt and actually figuring out what you were gonna write down.
I feel like for me, the process, it was like, there were so many things that we could hit. It's just figuring out what was really the main thing that we wanted to kind of focus on. There were so many ideas, and it was like narrowing it down to what can really be manageable.
Yes.
So.
Yeah.
I would say for me, I kind of related it to the work that I did before this, coming from a group home environment. I sat down with rehab specialists and we wrote IEPs together, and I kind of explained that to my group. We kind of focused on one overall goal and then wrote like 3 objectives. So that kind of was the long-term goal, and then short-term goals, and then intervention. So that's kind of how we were able to do it.
Yeah. To stay focused, it's very easy to get all over the place. We're gonna do this, and we're gonna do that, and we're gonna do this, and really stay focused on, when you're talking with your client, what is it that they wanna work on? Because if she's not ready for a safety plan, she might be, you might say, do you feel safe? And she might say, no, I don't. Well, is safety an issue that you wanna focus on? Like, are you ready to discuss that? Do you feel unsafe? Okay, like what would make you feel safer? Is she ready to leave her boyfriend? Because if you develop this grandiose safety plan, she's not ready to go. You're gonna spend a lot of time, and I'm not saying not to do it, and that's where the shared decision-making comes in, right? So is this something that you're gonna work on? If yes, then you really get down to that's really important. Safety comes first. If she's ready to do that, then good.
I
Yes.
think it's hard because we all come from different disciplines, so we all wanted to kind of bring our own agenda based on what we thought was important. And that was hard because the client, of course, the client's not here, so we can't really ask the client. So we kind of had to go by what we have experience with, what we think would be helpful to the client. So I think that's going to be challenging because we're going to think, well,
Again, you don't want to place your values and preferences on the client. And I'm not, like I said, I'm not saying we don't know. This is just a scenario that you're given. So you might sit down and you might find, I feel threatened by my boyfriend. I really want to work on getting out of this relationship. Great. Then you're going to start to obviously work on that. If she's saying, I'm intimidated, I don't like it, but I'm not going anywhere. I don't feel my physical safety is at risk. I don't have a child in the home, whatever, then, and I'm not ready to leave my boyfriend, then you have to really take that into consideration. If you are feeling unsafe, what is it that you're gonna do? Who do you reach out to? Who are your supports? That kind of thing. Do you have 911? Do you know how to do that? Do you know how to access crisis if you need to? All those things are really important. But again, what your long-term goals are gonna be is gonna be a shared decision-making process with your client. So, and it's very easy to get scattered. So remember, when you decide with your client, health, diabetes, medical, okay, what under that then are you gonna work on and what tasks? employment or, depression or substance use, what under that, maintaining sobriety, what under that? Yes.
I mean, what you say, we did all that, right? We had all this, and we have all this information here, right? Like she said earlier, it's hard to kind of pinpoint it without having that person in front of you.
Yes.
Exactly, because we all have our own ways of doing it.
Right.
And didn't get conveyed that.
That's why you're come up
beginning,
with
but-
different plans, because, you don't know when you have this scenario, you don't know what the person is saying back to you, right? So that's the problem in doing some of these things, is you're kind of gonna create, so in the shared decision-making process, developing the safety plan, you would think that that person was saying, yes, that is something that I really wanna work on. I feel like every day I think about my safety and my concerns in this relationship. It's limiting me and it's making me depressed and I sleep all the time and I need to do something about it. Great, okay, then you're gonna do that.
Yeah, we had all the concerns, but we just didn't, which one you pick first to go with. We know that if there's a crisis, you go with the crisis, but then there was so much situation that she was going through, that all of us had great ideas, but which one do you put into action first, you know what I mean? And that's what
Yep.
it was kind of difficult.
Does
Yep.
it matter?
Yeah.
Does it matter? If you're someone who has like 3 or 4 goals, does it matter which
Yeah, I
one
mean, you're
necessarily
generally
goes
gonna find what's
first,
more of
or-
a priority with the person. You wanna make your first one the priority, most
Well, we kinda
likely.
use the diagnosis as more
so-
of the primary. So the opiate use was the primary, and the domain was the depression, which was causing a lot of, the problems with the domestic. And then we actually used the medical after for the diabetes with the long and short-term goals. So we're kind of like all over the place, and I think after a while, we're here working and everybody was sharing their ideas.
Right,
And then
well, there's so many different ways you could go with this
Right.
case,
But we
right?
thought
So,
of the safety, like even though she wasn't here to ask, we knew that there was an issue in the home.
and again, in the discussion, she might say, I don't like it, I'm intimidated, but I don't feel unsafe. I don't feel like I'm gonna be physically harmed. I'm used to this. He calls me names all the time. So your discussion, or she could say, I'm really extremely bothered by this. It's depressing. I feel like picking up every time or shooting up every time he does this, and I need to, I'm ready to make some changes with my situation. So again, the stages
Well,
change.
it was clear, like her goals in the back, pretty much were there. I mean, she had a lot of resources already in place. She wanted a sponsor, she was on methadone maintenance. She was
Yep.
already attending meetings, but she wanted a job. Because I guess she didn't have any money, he was in control of everything.
Again, to stay as focused as you can on what your long-term goal is and then breaking it down.
We spoke at lunch, and we
is-
kinda
is,
lost.
Really the important part of the exercise too. Is there some, do you
I
have
said
a
after a
question?
while, we were together, and then we started smelling the lunch. And we took
Ah.
our papers, and we just kind of like threw it in.
Ah, okay.
So
Okay,
that's why we sort of like, seemed like we were scattered.
I got
Have to
it.
put everything in order.
But,
I just wanted to say, I feel like this was a great exercise to relate to what was said earlier, how easy it is to get lost and not having the enrollee at the center of care, and how it used to be the doctors and the providers, saying, hey, I'm the doctor and I know what's best, so I'm
Right.
the nurse and I know what's best.
Exactly.
Instead of the enrollee saying, no, this is what I want to work
Right.
on. I think that's how it kind of was at the tables, well, I'm a nurse and I know what's best from
Right.
this point of
Of
view, or
course.
no, I know what's best from this point of view, instead
Right.
of, her actually being here and saying, no, guys, I don't want to work on this. I just want to work on this.
Right.
I think this was great
Exactly.
for that aspect.
Yeah, yep. And I mean, your responsibility is to always make sure your clients have all the crisis numbers and emergency numbers, and if they feel any way, that their safety is in jeopardy, that they know who to call and where to go and how to reach us in case of emergency and all those things. But if they're not ready to end a DV relationship that they're in, You know, and again, there's a certain extent of DV, right? If somebody's getting smacked around the house and there's kids and then there's 51A issues involved, right? But if they're in a verbally abusive relationship and there's no kids and they don't feel like they're physically at risk, it's not okay for what's happening. I'm not justifying that at all. But there might be you know, you need to figure out where this woman is in terms of what she's, you know, what stage of change she's at with that relationship. And while you're doing the assessment, you're gonna figure that out, you know, by asking questions.
Yeah, and just,
Yeah.
you know, we were thinking it, because we wanted to put a lot of goals in place for this person, but, you know, because we're only choosing a couple of goals, we don't wanna overwhelm the person, but but we still have to address everything that's going on, so it's,
Right.
you know, we're still gonna provide resources for the other issues, like the boyfriend, and provide information and revisit that at every meeting and say, hey, how's that? Did you follow, you know, whatever, however you stated.
Absolutely.
Right.
She might not even understand that she's in a relationship that really, she's not being physically abused. She might be saying, oh, well, you know, I don't like being called names, but doesn't realize like the cycle of violence includes lots of emotional, verbal,
Or the
etc.
controlling of
There might
money.
just be an educational component as well. And she might not even be ready to hear you need to get another apartment or a sober house or a safe or a halfway house, whatever the case might be. She might just need education about that particular issue at this time. And again, it all comes down to the discussion and the assessment that you do when you're going to figure these things out. And you don't need to conquer everything. You need to really, when you're having that discussion, figure out what's important to her. What is it that she wants to see change? What are the things that are going to make her feel better? What does she want to focus on? So you're going to be getting a lot of that information when you're doing the assessment. But instead of you're analyzing the situation and then you're implementing your, you know, what you think she should work on. Yep.
I was gonna say sometimes certain resources can include, like for instance, she has all that going on, you know, she's not eating properly and she has the diabetes. She's not working, she doesn't have money, she's financially dependent on him. When we said that, and I think I heard them say it too, going to DTA as a resource, when she goes to DTA, she can use them for food stamps as well as applying for cash benefits. And some programs through DTA, in order to qualify for cash benefits, you have to go through a job training program or you have to go through a job searching work.
Right.
So it will tackle like three of the
different
issues
things
that
at
she's
once.
working on, which will be really
Yep.
great. So even though she just wants to work on finding a job, she'll have like three different things and she won't even realize that she's accomplishing those
Right.
things.
Another thing to remember with domestic violence, because it came up with the first cohort, is, and you know, there's no wrong answers, I'm not going to say that, but one of the plans came up with couples counseling. Couples counseling is contraindicated for DV, active DV relationships, and, you know, that's just something if it's active, whether it's verbal, emotional, physical, whatever, there's no, like, that could actually increase a safety issue if you're prescribing that she's going to be in couples because he doesn't want to do it, right? And so he's going to get angry that she even thought about it and talked about it and whatever else might happen. So that's just a rule of thumb to remember, that couples counseling is really contraindicated with active DV. So it came up with the first cohort, which is why I'm bringing it up.
Would you do something if he
Ariel
wanted?
is going to.
Sorry. Oh, would you do something in that situation that she's enrolled and she's experiencing domestic violence and a lot of it is stemming for, say, he has an anger issue and he wants to seek help as well? Then would you?
So if he was saying he wanted to seek help, then you'd want to see him seek help.
Okay.
And if he was able to get the help and show that he was really working on his anger and that he realized that this is what he was doing, then after all that, you might be able to do some couples work, but only if you saw him taking some responsibility and
Right.
doing something about
Okay.
it. And not just saying, oh, I'm sorry. That's
Right.
not enough.
But could you like refer
So-
him to like the
Yeah.
agency so that way he could get
Well, yeah,
started?
like I said, he would have to show that he was actively wanting to work on his behavior
Okay.
and his anger.
You just
in
wouldn't
order
leave him
to
by
do
the
that.
wayside.
Yeah, I mean, And that could be part of the assessment, is that you figure that out,
Okay.
that, you know. So as you can see, so much comes from the assessment, so.
So we have Loretta Johnson, who's a 33-year-old female with, sorry, substance abuse issues, depression, domestic violence, and diabetes. So what we did was one of her long-term goals was getting financially stable enough to move out of the house. And so we made some short-term goals to apply for DTA within the next 3 months. So that was really one of and then look for work was another one. So we have, that will help her fill out the applications for SNAP, get her to the DTA office, whether it's if we transport or we can have her find out who's someone that can transport her. And then she'll start to look for a job in, that she could do, online. Even if she has a computer, that's one of the things we kind of don't know, but we know she does want to work, as listed in some of the goals she has. Another long-term goal that we had was to manage her diabetes. Short-term goals were eating healthier, receiving the blood sugar monitor, which she mentioned she hadn't gotten yet, and exercising 2 times a week for 30 minutes. And then under that, we have that we'll refer her to her nutritionist, make an appointment with her primary care to help him, so he can help her get the blood sugar monitor, reaching out to her sister to go along for the walks maybe, that might help, making a workout calendar. The last long-term goal that we had was to maintain her methadone maintenance in the meetings, because she listed those as problems for her to be able to get there. So we need to help her figure out reliable transportation, so we could help her with looking at the bus routes and getting a PT1 form to get to methadone clinic. Apparently they do that, I didn't know that. So and that was pretty much what we had, and we looked at it using the share questions. We looked at it like, if you have all these issues, and these are what you want to work on, what are you willing to do? We also did talk about doing a safety plan. If she's not willing to move out, having her set up, what she can do to be safe if something were to happen. We also talked about that, or, if she was willing to go to, a domestic violence program, but we don't know that, it's not on here, so you can't really go by that until we can see the client. So that's what we came up with.
Great job.
Thank you.
All right, so for long-term goals, we stuck right to what how she answered the assessment. So the long-term goals, the 2 that we came up with were to stay in recovery and to be happy and healthy. So her short-term goal to stay in recovery was to abstain from her drug of choice. Her tasks were to continue her daily dosing and acquire the PT1 for that, because her transportation is a barrier. To continue with her meetings at a rate of 2 to 3 a week, and to identify a sponsor. So the anxiety and depression, her motivation levels, these were all challenges and barriers for both of the goals that we were dealing with. So it was just more of, if she, how do I want to word that? I'll do the other goal and then I'll finish the barriers. The other goal, as far as to being the long-term goal and being happy and healthy, her short-term goal was to really understand diabetes. So the tasks for that were bringing in a VNA program to really educate her on the importance of her medication, checking her blood sugar, properly administering the insulin, to
have a better diet, and that coincided with applying for the SNAP and being able to afford that, because she does want to be able to have a healthier lifestyle, but she did identify her finances. She was doing the best she could with what she had. And then getting out for a walk 20 minutes at least once or twice a week in her area, and identifying a support system to be able to help her stay motivated to do that, which we talked about her social support, which was her sister, and could also kind of coincide with the sponsor because, you know, fresh air and being active also helps with addiction. So with the challenges and barriers, going back to that, it all kind of went together, you know, the not having transportation and that getting the PT1 and helping her with those tasks there, and just put the controlling boyfriend, but you know, once her financial, getting to DTA and getting that finances in a little bit better of a situation kind of helps her feel better about herself and getting that self-esteem back. The lack of education was one of the big things for us, just in general. The lack of education of, you know, her diabetes, the lack of education of just resources in the area. So just continuing to educate her in all of those aspects, you know, how to get to the DTA, how to, you know, assist in applying for the PT1, how, you know, sending out these referrals for the different services that can educate her on the different little areas to kind of reach those. I think our biggest challenge at our table was our wording, as far as how we worded our goals, and just not wanting the client to feel overwhelmed by how the short-term goals are worded. We're all on the same page as far as the big picture, but I just feel like, you know, wording the goal to make it feel like it's reachable, as opposed to it just sounding so broad where it's overwhelming. That, you know, that's, as a case manager, when I did case management, as a case manager, if the goal just sounded too broad, it was almost like defeating from the beginning, because they feel like, oh, you're coming back to me in 3 months and you want this, you want that done. And so it was just, for us, it was like more of the, but I guess with the client present and being able to really engage them and have them set out their, you know, word their own goals, it would be a lot easier. But as far as like us sitting at the table together, I think that was our biggest challenge. That's it.
Thank you. All right, you all did a great job. I'm happy you guys are